My name is Roberto Zanetti. I am a medical doctor, an Italian medical doctor, retired. I retired some years ago from my position of epidemiologist. I spent all my career in cancer epidemiology. And now I am the president of the Fondo Elena Moroni, the organization that supports the Enrico Anglesio Prize. And in this position, I have the honor, the privilege, and the pleasure of introducing the award ceremony for the Enrico Anglesio Prize 2024 edition. The 2024 edition has been a great success in terms of participation, high number of competitors, one of the highest in the history of the prize. We had 24 people registered and then 19 finalists. And the finalists came from 15 different countries in 4 continents, Europe, North America, South America, and Asia. I will give the floor in a few minutes to another person that represents an organization that supports this prize, and this Mrs. Viola Ordini, the president of the Fondo Elvo Tempia, that supports the second award, the award given to the youngest participant, and this is a prize called Elvo Tempia Prize. So please, Viola, you have the floor for a short address for opening this ceremony.
Good afternoon, everyone. In 2020, we were happy to join the proposal of Professor Zanetti, who I thank, to establish a new prize in memory of my grandfather, Elvo Tempia, founder of the Fondo Edo Tempia per la lotta contro i tumori. Why did we take this decision? Because the Enrico Anglesio Prize, his history, his characteristic, and his objective appear to be fully consistent with the legacy of the grandfather and with the mission of our foundation, namely, among others, contribute to supporting cancer research and researchers, focus on young people and invest in them, stimulate fair competition, which is one of the conditions for progress in any field of science. The result of the 4 past editions, with 4 excellent winners of the Elvo Tempia Prize, confirm that our initiative was on the right direction. We are proud to be on board.
Thank you, Viola. We have already heard the greeting from Viola Ardini. Then Dr. Rosso will introduce the features of the prize. Then Mrs. De Sabata will introduce the new special prize dedicated to Harald Zurhausen. And this is a prize that targets the competitors coming from low middle income countries. Then the series of the presentation, the short presentation by all the 19 finalists, and then the winners will be declared and congratulated. And then finally, we will have a report from the alumni committee that will be done by Lidia Sacchetto. Before giving the floor to Dr. Rosso, I think that Francesco Petronella has to provide some short instruction concerning. Petronella is our IT manager, and he will give some instruction for running this meeting with the platform Zoom.
Good evening, morning, wherever you are, everyone. I'm Francesco Petronella, and I have the honor since 2020 to handle all the IT part of the Fondo and the prize. Just some quick instruction for everyone. First of all, please, all the panelists, if you have a cam, enable it, so we are able to see your reaction, your thought about what we are saying. You can't mute yourself alone. I will ask you to unmute. I will ask you when is your turn to give me some seconds to load up your slides. Please enjoy the ceremony, and please, Dr. Rosso, is your turn to speak.
Thank you, Francesco. Thank you, Roberto, for the introduction, Giardini for the greetings. This year, the Anglesio Prize returns in its virtual form, a decision we believe fosters broader participation. Despite the shift online, we have maintained the prize distinctive feature of recognizing young researchers, not only for their scientific excellence, but also for their ability in effectively communicate their study results. In addition to the main prize, we are pleased to have secured funds for two special prizes this year. The Elvo Tempia Special Prize, sponsored by Tempia Foundation. You have just heard the greetings from the president of the Tempia Foundation, Viola Verdini. And this prize is awarded to the youngest candidate who scores within the top tertile after the main winner. And the Harald Zurauser Special Prize. This award goes to the highest scoring candidate from a low or middle income country following the main winner. Dr. Stella De Sabata will shortly provide the inspiration and motivation behind this dedication. This year, we adopted a single-step evaluation process, building on insight from previous year, which demonstrated that assessing all the dimensions simultaneously yields better outcome. So the evaluation process involved a comprehensive scoring system that consider both dissertation and video presentation at the same time. Dissertation evaluates originality of the study, relevance to the field, appropriateness of the methodology, and consistency in the format of the submission. Furthermore, the candidates' curriculum were also reviewed with careful consideration of their years of professional activity. Videos submitted to applicants were evaluated on their ability to communicate the research message clearly, effective use of visual aids, means iconography, and adherence to time constraint. This is very important, especially in conference, to stick with the schedule. So here too, a weighted scoring system was used to ensure the balanced and fair assessment. The final scores for the prizes were calculated by summing up scores from the dissertation, video presentation, and curriculum rating. As Roberto mentioned, this year we had 24 candidates, but we received in the end dissertation and video from 19 applicants, representing diverse regions, including Europe, Asia, North America. Notably, 5 candidates were from low and middle income countries. The average age of applicants was 31, reflecting the increased time researchers now invest in their education and professional development. In recognition of this, we raised the age limit for participation to 40. But all of this would have not been possible without the dedication of our judges, who have taken on the challenging task of evaluating this submission with great care and diligence. I want to extend my heartfelt thanks to each of them, acknowledging their contribution in alphabetical order. So, our full-rank judges that participated in different editions, they are always there for supporting us, also promoting candidates and giving them opportunity. John Aiken from Australia, Claudia Alemanni from UK, Andrea Bordoni from Switzerland, Harry Comber from Ireland, Stella De Sabata from Switzerland, Jaume Galceran from Spain, Mohamed Sariri from Tunisia, Alexander Catalini from Germany, Betsy Colon from USA, Anne Corin from Uganda, Guy Lenoir from France, Dora Loria from Argentina, Tomohiro Matsuda from Japan, Marion Pineros from France, Sabine Sisling from the Netherlands, Hans Stoll from Denmark, Gisbert von Eycken from Belgium, and Vestas Darnik from Slovenia. But it's now time to give room to Stella De Sabata for the presentation of the Harald Zurausen Special Prize. Thank you.
Thank you, Stefano, and welcome everybody to this year's ceremony. I am talking to you from Rome. It's a wonderful sunny day, so inspiring weather for an award ceremony. And bit of cold still lingering. But anyway, I'm here to talk to you about the special prize, the Harold Zurhausen Special Prize. I have no slides, just personal memories and some reflections. I have very fond memories of Dr. Zurhausen that date back almost a quarter of a century, which does not make me any younger, but certainly grateful for the insights that Dr. Zurhausen shared with me. And sometime more recent than that, but still 15 years ago, I was managing the UICC Cervical Cancer Initiative, which Dr. Zurhausen chaired. And with us had more frequent interactions. We also traveled to Latin America together. And I remember Dr. Zurhausen as a very kind, soft-spoken man, generous with his advice and putting science within the context of its application so that the best possible outcome could be reached in a real-world setting. To me personally, he was very kind in that he let me speak my artistic German with him. I never learned it at school. And also, as already a Nobel laureate, he wrote a reference letter for me. I am sure that Dr. Zurhausen would be very pleased that Fondo Elena Moroni established a prize to encourage a researcher from a part of the world where even more effort is needed to attain academic excellence and recognition. And I am also sure that he would be very pleased, as we all are, with the willingness of such researchers to share the work and dedication for the betterment of their communities and to be in an environment where they can interact with peers from all over the world. But you'll hear more about that from Lydia in the second part of the ceremony. So we look forward to discovering the inaugural awardee of the Harold Zurhausen Special Prize. Back to you, Stefano.
I guess that now is the turn of Lydia Sacchetto, who is Vice President of the Fondo Elena Moroni, to introduce our candidates, also in force of her role as President of the Alumni Committee. Please, Lydia.
Stefano, and now it's time to give the floor to our participant, who will shortly introduce their work. They have the possibility to share a slide and to talk for about 2 minutes about their work. The final ranking of the contest is totally independent from this presentation. We want just to give to our great contestant the possibility to have a bit of visibility and to share some things with us about their work. To make the atmosphere a bit more relaxed and to break the tension, now and then I will also ask some of the jurors to say a few words. We will go in alphabetical order, and please excuse me since now for any wrong pronunciation of your names. So let's start from Dr. Baltus from University of Lübeck, Germany, who will talk about a micro simulation for the risk-adapted skin cancer screening in Germany. Dr. Baltus, the floor is yours.
Thank you very much. I've got a slide. My topic is a microsimulation for risk-adapted skin cancer screening. A microsimulation you use if you want to do a screening, but you don't have the resources or other problems with doing an RCT before starting to do a screening in a country. And the idea is you take a lot of input variables like official life tables or the tumor size at diagnosis and tumor growth rates and age when a tumor becomes screening detectable, and simulate this population and then see what happens if you offer screening to this population. So you can compare this simulated population. In this part, I added risk factors to the populations. So known risk factors for skin cancer, like having a particularly light skin or having a lot of nevi, And these risk factors both influence the probability to develop cancer in my population, and they also influence the probability of taking part in the screening, so that we can see if there might be possibilities to improve the already existing skin cancer screening in Germany. And the results are, yeah, it would be possible, but there still needs to be further study to find out which risk population should be the one that gets offered more screening more often. Yeah, thank you.
Thank you very much, Dr. Baltus. Now it's the turn of Dr. Catalano from University of Turin, Italy, who will talk about socio-economic position and risk of differentiated thyroid cancer in the EPIC study, identification of possible mediators. Dr. Catalano, the floor is yours.
Perfect, thank you. Also for the opportunity. I'm trying to share the presentation. This project was conducted in collaboration with University of Turin and International Agency for Research on Cancer. And the main aim of this study was to evaluate the association between socioeconomic position and differentiated thyroid cancer. We wanted also to evaluate some variables such as BMI and thyroid-related biomarkers in this association. And for doing this, we conducted analysis using an innovative statistical tool known as mediation analysis that allows us to split the standard total effect between the exposure and an outcome into two different effects. The first is the direct effect that expresses the direct and real association between the socioeconomic position and differentiated thyroid cancer, but also the indirect effect that expresses the association between an exposure and an outcome that passes through the potential mediator, that in our case are BMI and biomarkers. And from the results, I found that a lower socioeconomic position directly and significantly increased the risk of developing the differentiated thyroid cancer. And regarding the mediators, we found that the BMI is a key mediator in this association, while thyroid-related biomarkers are not mediator of the association between socioeconomic position and differentiated thyroid cancer. And in my opinion, these results are very important because they highlight the importance of implementing policy for subjects with a lower socioeconomic position in order to eliminate whole health inequalities, but also highlight the importance of maintaining healthy lifestyles and normal BMI in order to reduce the risk of adverse events, for example, differentiated thyroid cancer. So this is my project, and thank you for this opportunity.
Thank you, Dr. Catalano. Now let's continue with Dr. De Stefanis, again from University of Turin, Italy, who will present on update of the best prognostic model for metastatic prostate cancer in an Italian cohort. Dr. De Stefanis, the floor is yours.
Yes, thank you very much. Can you hear me well? And I also have a slide. Yes. So hello, everyone. I'm a PhD student at the Cancer Epidemiology Unit of the University of Turin. And this is a very brief overview of our work updating prognostic models for prostate cancer. So this study is based on the Turin prostate cancer prognostication cohort, which includes non-metastatic prostate cancer patients diagnosed between 2008 and 2013 at Turin's main hospital. So as you can see, beyond standard clinical data, we integrated histopathological findings, tumor DNA methylation data, and deep learning features from digitized slides. And the main objective of this work was twofold. So first, we aim to update four widely used prognostic models, the D'Amico, Capra, Predict Prostate, and MSKCC. And then we aim to develop a novel approach for the selection of patients for active surveillance using predictive 5-year metastasis risk rather than categorical protocols, something that is especially relevant as active surveillance protocols increasingly consider patients with ISO grade group 2 prostate cancer. So moving on to the results, MSKCC showed the highest discrimination for metastatic prostate cancer at 5 years, with an optimism-corrected C-index of 0.83. And how can we now use this for better selecting patients for active surveillance? So in the tables, you'll see some of the most commonly used protocols for active surveillance. And for each protocol, we calculated the 95th percentile of MSKCC's predicted 5-year metastatic risk. And just as an example, by setting a metastasis risk threshold based on MSKCC prediction that is averaging all the above ones, you can see that we identified more candidates for active surveillance while also maintaining low metastatic risk, which could allow for more nuanced treatment decisions. So our next steps will include, of course, exploring whether deep learning and DNA methylation markers could further improve prognostic accuracy. So finally, I'd like to thank, of course, my team, the IARC Foundation for financial support, and you for selecting our work as a finalist for the Enrico Anglesio Prize. So thank you.
Thank you, Dr. De Stefani. And now the floor goes to Dr. Godoy from Pontificia Universitat Javeriana in Bogotá, Colombia, who will talk about age, period, cohort effects on incidence trends of childhood leukemia from 4 population-based cancer registries in Colombia. Dr. Godoy, the stage is yours.
So, as you may know, Colombia, one of the most biodiverse nations, proudly hosted COP16, underscoring its commitment to both environmental conservation and advancing public health. While facing challenges typical of middle-income countries, Colombia is making meaningful progress in cancer research with a particular focus on understanding childhood leukemia. Monitoring these trends is crucial to reducing health disparities and ensuring equitable care for all children. I'm Natalia Godoy, a medical doctor and epidemiologist, and during my PhD, my colleagues and I conducted a study that aimed to examine incidence trends of childhood leukemia and assess the effects of age, period, and birth cohort. We employed cancer registry data from 4 Colombian cities and applied joint point regression to identify changes in trends. We also applied an age period cohort model to assess the effects of age, time period, and birth cohort on leukemia incidence. Moving into the results, we identified 966 cases. The age standardized incidence rates per 100,000 person years ranged from 3.89 in Manizales to 7.27 in Bucaramanga. Significant increasing trends in acute lymphoblastic leukemia were seen in Cali and Bucaramanga. Concerning age period cohort models, age was the primary factor driving childhood leukemia incidence, peaking in children aged 0 to 4, consistent with global trends, with a strong model alignment in Bucaramanga and Manizales. However, in Cali and Pasto, distribution suggested other influencing factors. Although overall rates showed no significant change, notable fluctuations in leukemia subtypes may be linked to pesticide exposure, especially in rural areas. As Colombia strengthens its legacy in environmental commitment as the host of COP16, this study underscores the importance of using population-based cancer registries to understand health patterns in childhood leukemia across diverse regions throughout the country. Targeted resource allocation and focused efforts are essential to address these health disparities, particularly in areas vulnerable to environmental risks across our diverse country. Thank you.
Thank you very much, Dr. Godoy. And now, before continuing with the scientific presentation, let's ask for a short comment to the juror, Dr. Betsy Kohler. So, Dr. Kohler, the stage is yours.
Thank you. I'd just like to say I was really impressed with the dissertations this year. We had a large number of them, and they were really of superior quality. I've been doing this judging for several years now, and it's always an honor and a pleasure to review the work of the young scientists around the world in our field of cancer surveillance and cancer epidemiology. So thank you for your hard work, and keep it up. I hope this becomes your professional career.
Thank you, Dr. Kohler. We can continue now with Dr. Wang from Academia Sinica in Taipei, Taiwan, who will present a study on a stabilized age period cohort creaking method for disease mapping and application to arsenic-related cancer in Taiwan. Dr. Wang, the stage is yours.
Hello, can you hear from me? Yeah, so let's get started. You can see my slide. The Blackfoot disease is a condition caused by chronic arsenic exposure. Was once spread in southwestern Taiwan, seen in the part during the 20th century. Our study used the Taiwan Cancer Registry data to examine the arsenic-related cancer rates in Blackfoot disease endemic areas compared to the rest of Taiwan. While the registry began providing the high-quality data only in 1995, limiting the long-term trend analysis. So we addressed this issue by focusing on the first cohort trend to explain the changes in disease prevalence. To enhance our analysis, we developed a spatial temporal mapping method using a random effect age period cohort model. This model estimates the disease rates in each administrative unit, and we applied interpolation techniques like a kernel density estimation or a stabilized bridging to map this pattern across geographic locations. After running the Monte Carlo simulations, stabilized bridging emerges the most accurate method. While with these tools, we create details such you can see the contour map and the tangle map and climatic visualization that brought the spatial temporal trend to life. Our finding, you can see, show that the cluster of high incidence in southwestern Taiwan, and the cluster began to narrow after a 1960 first cohort, aligning with the start of the Blackfoot disease prevention measures. So this innovation approach not only demonstrated the strong predictive powers, but also offer a valuable insight into arsenic-related cancers, contributing meaningfully to public health research and policies. Thank you for listening.
Thank you very much. And now it's the turn of Dr. Jurtela from Institute of Oncology, Ljubljana, Slovenia, who will talk about predicting lung cancer incidence using age period cohort models and smoking prevalence data.
Thank you very much for the introduction. And would you please share my slide as well? Thank you. So I am Maja Jurtela from the Slovenian Cancer Registry, and our study is about predicting lung cancer incidence using an age period cohort model with smoking prevalence data. So since smoking is responsible for 85% of lung cancer cases, in our study, we combined 6 years of lung cancer incidence data from our registry and with the populational data, and then also with smoking prevalence and intensity data from national health surveys. So this way, we assessed the future incidence of lung cancer in Slovenia up to the year 2040. And our results showed that the lung cancer incidence in males, which is shown on the first graph, has been consistently elevated during the period from 1960 to 2020. And our model predicts for the period 2021 to 2040 that the incidence will decline in most age groups. But women have had low incidence, which is shown on the second graph, and our model predicts a substantial increase in women aged 70 to 89, especially which is driven by the smoking habits, especially in those birth cohorts of the women in 1960s and 1970s. So our results suggest, which we can see on the table on the left side, that the currently studied lung cancer screening programs, which target ages 50 to 75 in both sexes, which are shown within the yellow squares, they may miss a substantial number of future cases since they have a possibility of capturing the population with 60% of cases in males and 50% of cases in females. And the future screening programs would capture the highest percentage if they targeted males of ages 60 to 86 and women of ages 65 to 89. So in conclusion, we believe that at planning possible screening programs, predicted future screening, future lung cancer incidence should be taken into account, particularly to address the rising incidence among women. So thank you very much.
Thank you very much, Dr. Jurtela. And now we can continue with Dr. Mafra da Costa from Luxembourg Institute of Health, who will talk about the RELIANCE breast cancer study, insights into data linkage and return to work. Dr. Mafra da Costa, the stage is yours.
Thank you. Just waiting for the slides. Thank you so much.
My name is Aline. I'm from Luxembourg, and I decided to send for the dissertation submission the work that I've been working since 2 years now. That's the Reliance Breast Cancer Study, is a pilot study to understand how we could better link age data and also understand the return to work. The idea started because we know that when we analyzed the objectives of the study, we understood that we would separate in two big steps. The first step was to evaluate all the data that we have in the cancer registry, the cohort of breast cancer, and the second one, explore how we could improve data linking other data. So in the step one, when we analyzed, we understood that 2/3 of the patients, the breast cancer patients, they were diagnosed during the working age. Mainly of those patients, in the future, after the treatment, they probably return to work. And for that, we tried to understand how we could better linkage the data, considering that the database, the cancer registry in Luxembourg, is a pseudonymized cancer registry. So we don't have access to the nominative data. So understanding everything, we decided to do a collaboration with the STM, that's the Occupational Health Service here in Luxembourg. And with the STM, we designed all the documents of the study, invitation letter, information document of the study, data protection notes, informed consent form, and the questionnaire of the study, together also with a patient partner. And we designed this flow chart here to better understand how we could link the data, but also protect these patients, considering all the regulations of the GDPR that here is quite strong. So for that, we designed this flow chart, and here we have 3 tables of correspondence to protect the nominative data of these patients, and in the end, make everything inside of the regulation. So here, I'm bringing some few results. In the questionnaire, we had a score. That's the workability index that is usually used in the field of the occupational health service. And here we have some variables coming from the cancer registry. For example, the age at diagnosis. We can see that patients with 50 or more, they had better scores when comparing with other ages. For the workability index, the type of surgery, mastectomy, the clinical stage, the early stage, they had better workability index, and also the work activity mixed showed to be the better workability index. This is just a few examples about how the potential of our results. We have many data yet to explore. Here I'm leaving the QR code if you are interested and you want to check it out a bit more about what we are doing. And thank you so much.
Thank you very much, Dr. Mafra da Costa. And now let's have again a short break. And I would kindly ask this time to the juror, Dr. Sabine Sisselin from Netherlands, to share a funny memory on the prize. Sabine, the stage is yours.
Thank you very much. I really enjoyed judging and looking at all the presentations. Indeed, as Betsy Kohler already mentioned, the level of presenters and the level of studies and results is very high. And I have the feeling that I have a kind of private conference sitting in my room, having a coffee and seeing all those very nice presentations. So compliments to all of you, all the participants. I had an enjoyable day that day. So thank you very much. Thank you, Lydia.
Thank you. Thanks a lot. And now let's continue. And from Netherlands, we move to Germany, where Dr. Metzger from Martin Luther University in Halle-Wittenberg will talk about NCCN Guideline Concordance Cancer Care in Sub-Saharan Africa. Dr. Metzger, the stage is yours.
Thank you. My name is Nicolas, and I'm happy to present our collaborative research between Halle University and the African Cancer Registry Network, AFCIN. To set the stage, cancer is a public health issue in sub-Saharan Africa, which is growing. However, little information is available on clinical cancer care, especially on population level. In this study, we cooperated, therefore, with 11 cancer registries in 10 countries, which you can see on the map on the left. And from these cancer registries, a random sample was drawn with 5 different cancers, and baseline epidemiological data was supplemented with clinical information on diagnostics and therapy. The NCCN harmonized guidelines were specifically developed for Sub-Saharan Africa and we used these guidelines to evaluate the clinical cancer care data that we collected. And as you can see on the bar chart on the right, we found around half of patients with non-Hodgkin lymphoma and breast cancer treated in concordance with the guidelines. So those are the bars in green and yellow. But only 1/3 of the colorectal cancer patients and even less patients with cervical cancer. Now, our study on the quality of treatment at population level can be a baseline for policymakers drafting and advancing the national cancer control policies, and our study can also help set priorities. And in light of the restricted resources in Sub-Saharan Africa, these priorities should attempt and address several issues at once. For example, improved pathological services could increase staging in breast cancer, but also in prostate cancer. In increased availability of radiotherapy devices will support treatment in breast, cervical, rectal, and in prostate cancer. And improved surgery will benefit, in fact, all cancers, because even in lymphoma, a surgical biopsy is needed in the diagnostics. And with that, I thank you and look forward to the rest of the ceremony.
Thank you very much. And now it's the turn of Dr. Nemati from the International Agency for Research on Cancer in Lyon, France, who will talk shortly about the potential impact of tobacco control policy in preventing incident tobacco-related cancer in the Eastern Mediterranean region, 25 years projection from 2025 to 2050. Dr. Nemati, the stage is yours.
Hello, everyone. This is my great pleasure to present in this award ceremony. In this study, we investigated the effect of implementation of 3 policies, including maximizing the trace rate, implementing Empower package of WHO at the highest level, and also increasing 10% in affordability index in relation to the number of cancer that could be prevented in the next 25 years in the EMRO region, which refers to the countries in the North Africa and the Middle East, where we use the fixed-term regression to investigate the association between those policies and prevalence of tobacco smoking, and then use the regression coefficient to investigate the prevalence under each scenario. Then we calculated population attributable fraction under each preventive scenario and multiplied the difference between population attributable fraction with alternative scenario from population attributable fraction with current prevalence of tobacco prevalence, and then multiplied it to the number of projected cancer. Finally, we projected 40 million cancer to be occur in the next 25 years in the EMRO region, and then more than 400,000 cases could be prevented if we implement all these policies in that region. The low and middle income countries like Afghanistan, Pakistan, and Yemen would have the most benefit, and the less improvement was observed in Saudi Arabia, Egypt, Lebanon, and Jordan. Thank you so much.
Thanks a lot. And now I will give the floor to Dr. Orbe Munoz from the Instituto de Luca Control and Cancer Solca in Cuenca, Ecuador, to briefly present on the geography of cancer spatial distribution. Dr. Orbe Munoz, the stage is yours.
Good morning. I have to tell I am not fluent in English, so I'm going to try my best. Our research has been conducted with considerable effort and originates Ecuador, a developing country where research of comprehensive health studies are often made despite the challenges. We are deeply committed and to advancing knowledge in cancer epidemiology. Our research examined spatial distribution on cancer, focusing on how socioeconomic factors, environmental conditions, healthcare access contribute to cancer incidence across different regions. By applying health geography principles, we aim to standards complex interactions between these variables and how impact cancer rates and health outcomes. The province Azuay, with its capital Cuenca, is constituted in area urban. It offers a specialty of oncology centers, resulting in higher cancer detection rates that better access and healthcare facilities. The rural areas affected by long travel distance, which create barriers, the shortage and healthcare infrastructure, and the special personnel limits early detection. Impact. Significant disparity in cancer incidence between urban and rural areas. Need target interventions bridge the gap. Cuenca Cancer rehearsed a document over 50,000 cancer case since 1996. This registry allows us to estimate the geographic distribution of cancer across of Cuenca and its surrounding areas, the shielding line of parents and disparities in cancer incidence. Or one of the case findings was the significant disparity in cancer incidence between urban and rural areas. This urban and rural gap is also impacted by shortage and healthcare infrastructure and specialized person and rural areas. Or they reveal the most common types of cancer affect the digestive and family reproduction systems, and notably the cancer incidence rate in Cuenca is doubling over the past 2 decades. This increase is especially pronounced among individuals aged 15 or older, underscoring the age-related risk of cancer and growing healthcare burden in the regions. To address these challenges, our study highlights I need early detections, environmental research, increased health educations, and further research into environmental factors. In conclusions, I extend my sincerest gratitude to AIP 2024. I am more than happy to address any thank you for your attention or look forward to discussions.
Thank you very much. And now we can continue with Dr. Park from the National Cancer Center in Goyan, South Korea, who will talk about the breast cancer paradox in South Korea, investigating high-risk areas of breast cancer by summary stage through the spatial temporal model-based cancer incidence surveillance systems. Dr. Park, the stage is yours.
Yeah. Hello, my name is Une Park. Thank you for giving me the opportunity to share my research. My research is about the breast cancer paradox in South Korea. Breast cancer paradox refers to a phenomenon. The private area were associated with lower breast cancer incidence and higher breast cancer mortality. When we break down breast cancer incidence by stage, we could find the private area tend to have a lower early breast cancer incidence and higher advanced breast cancer incidence compared to affluent area. So the aim of this study was to identify high-risk areas of breast cancer by summary stage and examine the association between breast cancer incidence and regional risk factor, especially the areal deprived index. I utilized the Korean Cancer Registry data from 1999 to 2018, and I applied Bayesian hierarchy model to identify cancer cluster and analyze association with regional risk factor. To summarize key finding, breast cancer incidence have been increasing for 20 years, and high-risk areas for breast cancer differ by summary stage. And area deprived index were inversely associated with localized and distant metastatic breast cancer. This is the first study to examine how regional socioeconomic status affect breast cancer incidence by summary stage using population-based cancer registry. And these findings support targeted resource allocation to high-risk areas, aiding cancer control efforts in South Korea. Thank you for your attention.
Thank you very much, Dr. Park. And now we have already listened to more than half of our contestants. Before proceeding, I would like to ask to the Vice President of the prize jury, Dr. Vesna Zlatnik, to talk a bit about her memories on the prize. Dr. Vesna, the floor is yours.
Thank you, Lydia. Good afternoon, all of you. I'm really glad I can participate this year again. It is every year my honor to be a part of the jury member for the last some years. All these well-prepared theses give me personally a new drive for cancer research, for mentoring. But what is even more important, I see how my younger colleagues get the input to work in the cancer epidemiology research even in the further years. So here I would like to take this opportunity to thank the Fondo Elena Monroli, to thank you, Professor Roberto Zanetti, Stefano Rosso, Lydia, that you are running all these times this prize, and we are glad all the jurors and the candidates that we are able to participate in the prize.
Thank you, Vesna. Now let's continue with Dr. Peyrelink from Belgian Cancer Registry inside Jossen ten Noot, Belgium, who will talk about lung cancer care during the COVID-19 pandemic, a resilience test for the Belgian healthcare system. Dr. Peyrelink, the stage is yours.
Good afternoon, everyone. I'm Hanna Perlink, and I'm working as a data analyst at the Belgian Cancer Registry. So in Belgium, we observed a decline in one-year relative survival of patients diagnosed with lung cancer during the pandemic. Given the vulnerability of lung cancer patients and the tremendous pressure on the health system by the pandemic, we hypothesized that alterations in their care trajectory might be responsible for this decline in survival. In this study encompassing almost 30,000 patients, we made use of nationwide mandatory cancer registration and health insurance data to evaluate the impact of COVID-19 on diagnosis, treatment, and outcomes of lung cancer patients. Results from the COVID year 2020 were compared to the reference period 2017-2019. We found that in general, patients diagnosed during the COVID pandemic were frailer with a poorer WHO performance status and more respiratory comorbidities. In terms of stage, patients more often presented with metastatic disease on one hand, but on the other hand, also slightly more stage 1 diagnoses were made. Surprisingly, despite the pressure on the respiratory wards and intensive care units, the care trajectory was only mildly impacted. It appears that once patients had received a diagnosis of lung cancer, they received standard and timely treatment. The 90-day post-operative mortality was higher than what would be expected, while the 1 and 3 year relative survival seemed to stagnate, but did not differ significantly from expected estimates. We presume that community-acquired COVID-19 infection or the lack of social support driven by the social isolation protocols may have played a role in the delayed post-operative mortality. In conclusion, the Belgian health system proved to be resilient in the care for lung cancer patients. I want to thank you for this opportunity to present this research. Thank you very much.
Thank you to you. And now we proceed with Dr. Prince from the Central Brain Tumor Registry in Insidale, US, who will shortly present her work on geographical variation in the association between exposure to ambient air pollution and brain tumor incidence across US countries. Dr. Prince, the stage is yours.
Hello, thank you for this opportunity. We collected county-level average annual age-adjusted incidence rates for diagnosis years 2004 to 2020 for those who were aged 20-plus years from the Central Brain Tumor Registry of the United States, which is a combined data set of the CDC's and NCI's cancer registries and covers the entire United States population. We also got county-level data for air pollution for a 16-year period, which allowed for a 4-year latency prior to diagnosis. We performed a multi-scale geographically weighted regression, or MGWR, which creates an individual regression model for each individual county in the United States. And then we compared these results to a traditional global logistic regression model, which assumes a constant relationship across the entire country. We adjusted for 12 variables, selected a priori for their known association with increased pollution exposure or brain tumor risk. The results you can see. The global model found a significantly statistically positive association between air pollution and brain tumor incidence overall, and when restricted to just gliomas or tumors of the meninges only. Figure A shows that the MGWR model also found a significantly positive association between ambient air pollution and brain tumor incidence in all of the counties included in our analysis. This association was only significant in 22% of included counties when restricted to gliomas, as seen in Figure B. And in Figure C, you can see that among tumors of the meninges, this association was only significantly associated with increased incidence in 59% of included counties. To our knowledge, this is the first manuscript to apply spatial variability through MGWR to evaluate the association between brain tumor incidence and ambient air pollution. Considering the limitations of our study, further research is required to validate these findings. However, MGWR did allow for the magnitude, direction, and significance of coefficients to change across the geographic space. This allows for a more accurate identification of geographic regions affected by health disparities, which would be better for improving resource allocation and targeted policy. Thank you for your time.
Thank you so much. From the US, we make a big jump back to Europe, and I please to let the stage to Dr. Schwarz from Johannes Gutenberg University in Mainz, Germany, who will talk about identification of pancreatic cancer cluster for survival analysis using machine learning. Dr. Schwarz, the stage is yours.
Hello. Thank you very much for this opportunity to present some highlights of the study we submitted to this competition. My name is Lisa Schwarz, and I'm doing my PhD in Germany, and I try to apply machine learning algorithms in cancer research. In our work, we focus on pancreatic cancer, which is a highly deadly type of cancer and often diagnosed at advanced stage. And until today, the treatment options remain limited, and there's a need for reliable survival analysis. This work was done in collaboration with the Cancer Registry in Rhineland-Palatinate in Germany, and we investigated the data of about 940 patients which had a diagnosis of pancreatic cancer between 2016 and 2023. We used an easy and straightforward approach. First, we performed a Cox regression on all data, and then we performed a machine learning clustering called the PAM algorithm with gather distance to cluster the data into more homogeneous groups. And using this approach, we identified 5 clusters. And in the last step, we then performed a Cox regression on each cluster identified. Our results show that we identified 5 well-defined, distinct, and meaningful clusters of pancreatic cancer patients. And additionally, 4 out of 5 Cox regressions showed a significant improvement in comparison to the Cox regression, which was performed on all patients. So this approach could therefore help identifying meaningful subgroups of pancreatic cancer patients. And additionally, this approach has the potential for further investigation and research, and we are currently working on this. So again, thank you very much for this opportunity.
Thanks a lot. And now it's the turn of Dr. Slotman from the Netherlands Comprehensive Cancer Organization in Utrecht, Netherlands, who will talk about guidelines versus real-world data in metastatic bladder cancer, a population-based study on first-line chemotherapy treatment patterns. Dr. Slotman, the stage is yours.
Hello everyone, I'm Alice and I'm a PhD candidate at the Netherlands Comprehensive Cancer Organization. And today I will shortly tell you something about my study on first-line chemotherapy treatment patterns for metastatic bladder cancer. And for that I want to introduce you to John. John has been diagnosed with metastatic bladder cancer, quite a poor prognosis, a median survival of 5 months. And his oncologist tells him that according to the guidelines, 4 to 6 cycles of palliative chemotherapy is the recommended treatment. But we know that guidelines are often based on the results of randomized controlled trials who include fitter and younger patients than John. So a question that John may have is, how likely is it that I can benefit from this treatment and adhere to this treatment? And therefore, the aim of our study was to provide real-world insights into first-line chemotherapy treatment patterns for metastatic bladder cancer, in which we included the number of cycles patients received, adjustments that were made to treatment schedules, and the reasons for these adjustments. And for this, we used data from the nationwide Netherlands Cancer Registry. So, what were our main outcomes? First of all, 40% or 4 out of 10 patients had to stop treatment before the guideline recommended number of treatment cycles was reached. So they received less than 4 cycles. 60% of patients did receive the recommended 4 to 6 cycles. And we also observed that male sex and a better performance status at diagnosis were independently associated with receiving the 4 to 6 cycles of chemotherapy as recommended by guidelines. But also in patients who received those 4 to 6 recommended cycles, treatment adjustments were quite common in nearly 50% of patients, and mainly these were dose reductions due to side effects. And this is, of course, a very brief description of the results, but they already show us that adhering to guideline recommended treatment is very challenging for many patients with metastatic bladder in daily clinical practice. We see that discontinuation and treatment alterations are very common. And therefore, we believe that it's crucial to incorporate these insights into shared decision-making with patients like John, so that he can make a well-informed decision about whether this treatment is in line with his wishes, his preferences, and his needs. And with that, I would like to end my short talk today, and I want to thank the organization for giving me the opportunity to share my research here today.
Thank you very much. Now, before continuing with the last candidates, I would kindly ask the juror Stella De Sabata to share some memories on the prize as well.
Thank you, Lydia. I think that my best memory of the, let's say, post-COVID time is being together in Turin. So I do hope that we can go back to that. Also because it was not only a time for jurors to be together, but for youngsters as well. Both candidates and alumni, I think it's the being together that makes our bonds stronger. And I really look forward, and I'm repeating yourself, to your presentation, Lydia, afterwards of the alumni committee, because the prize is just one moment in time, but the thing that lasts is the community. So what stays with me is the good memories, and from year to year to get to know new cohorts of young researchers. And I think that we really have very good hopes for the future of epidemiology and cancer registration, much more than in other professions where maybe the education is not as strong as you guys are showing us. Thank you.
Thank you very much for the kind work. And now we can continue the scientific presentation and going to Switzerland, where I want to give the floor to Dr. Suter from the University of Zurich, who will talk about the effect of COVID-19 pandemic and lockdown on cancer stage distribution and time to treatment initiation using Swiss cantonal cancer registry data. Dr. Suter, the stage is yours.
Perfect, thank you. So, hi everyone, I'm Florina, a PhD student at the University of Zurich. I'm grateful to be one of the Enrico Anglesio Prize finalists and to have the opportunity to present my work. So we investigated the effect of the COVID-19 pandemic and also of the lockdown on cancer stage distribution and time to treatment initiation using Swiss cantonal cancer registry data. Coinciding with the implementation of the public life lockdown in Switzerland, the number of COVID-19 cases decreased. However, we were interested to know whether the pandemic and also the lockdown had an effect on cancer outcomes. We used data from the Swiss cantons of Zurich and Zug from 2018 to 2021. We first conducted some descriptive analysis and then fitted multivariate regression models. In our study, we observed a 10% decrease in cancer cases of stage unknown and a slight increase in stage 2 and 3 cancer cases during the pandemic compared to pre-pandemic. Additionally, we observed that patients diagnosed in 2020 had shorter time to treatment initiation when receiving chemotherapy and patients diagnosed in 2021 had actually longer time to treatment initiation when receiving surgery or hormone therapy compared to those diagnosed pre-pandemic. So to conclude, we did observe an effect of the pandemic on cancer outcomes in Switzerland. However, we have to be aware that the new Swiss law on cancer registration implemented in 2020 might also have had an effect on cancer outcomes. I would like to thank all my co-authors, the team at the Cancer Registry, also the University of Zurich and the University Hospital of Zurich, the funder of this project, the Swiss Cancer Research, and you for your attention. Thank you.
Thank you very much. Now let's continue with Dr. Trallero from Catalan Institute of Oncology in Girona, Spain, who will talk about survival trends and cure rates of childhood hematological neoplasm, a population-based study in Spain. Dr. Trallero, the floor is yours.
Hello to everyone. I'm Jan Trallero from the Girona Cancer Registry in Northeast Spain. And on behalf of the Hematordecan Working Group, I'm presenting this work, that is Survival Trends and Cure Rates of Childhood Hematological Neoplasms, a population-based study in Spain from 2000 to 2016. And the background behind this work was that childhood leukemias are one of the first causes of death in Spanish children, mainly in children that are aged between 5 and 9 years. And the previous studies focusing the pediatric Spanish population provided outdated results from 1991 to 2005 and a low coverage population of around 29%. So in this work, the Spanish network of cancer registries, we match our data with the Spanish Registry of Childhood Tumors to increase the population coverage to almost 65% of the population and providing data for a more updated period. So the statistical analysis that we did were first descriptive statistics for all the data, and then we used flexible parametric survival models to estimate survival estimates at different times, at 1 year, 3, 5, and long-term projections at 10 and 15. And also we evaluated survival trends and we estimated cure rates. So the main results were that in this study, 4,706 cases of hematological neoplasms in children were included. Mainly all cases were leukemias, childhood leukemias, and the results showed that overall hematological neoplasms at 5 years in diagnosis in children have a good prognosis of 84%, almost 85%. And the results on trends, we modeled trends and giving the increased percentage between the years, we saw that there was an increase of 0.7% annually, an improvement on the survival of these diseases. And also the final result of the cure rates show that around 84% of children that are diagnosed with this kind of disease can be cured. And thank you for your attention.
Thank you very much. So let's go now to Dr. Zanga from University of Milano Bicocca in Milan, Italy, with a work on federated learning for personalized treatment in a multicentric study on endometrial cancer. Dr. Zanga, the stage is yours.
Thank you so much. My name is Alessio. I'm a PhD student at the University of Milano Bicocca, and today I will show you my results from the PhD that I delivered, the PhD thesis that I delivered 2 weeks ago. On the left, you will see an early simplification of the old framework. The idea is that when we deal with multidimensional settings, such as cancer, we have different kind of interactions and associations that we want to basically exclude and remove from the whole explanation. In order to do that, when we have multiple drugs, multiple covariates, and different kind of outcomes, we have to apply an approach that is called causal discovery. Basically, the idea is that we have to remove through, for example, hypothesis testing or score maximization, different kind of interactions, and fuse together different kind of prior knowledge from clinicians in order to obtain a model that is capable to explain with this kind of graphs, arrows, the connection between variables. On the right, you can see the developed methodology, which is basically a generalization of this approach in a federated environment. As you all know, data are usually scattered across multiple sources, and in order to fuse them together, there are different kind of approaches. But in order to preserve privacy and get different kind of results, usually federated learning is quite effective. So without moving data, we learn local models and we fuse them together in a federated approach in a server, a centralized server. What we learned in this setting, so in the endometrial cancer setting, is that without pulling together different kind of data, we are more effective in explaining the interaction between treatments and outcomes, especially when we have different kind of missingness patterns. For example, missingness not at random, where practical clinicians usually try to adapt their treatment given a specific setting or given a specific guideline. Thank you so much for the opportunity of being present here today.
Thank you very much, Dr. Zanga. And now I've seen that Dr. Krishnan has been able to rejoin the meeting. So Dr. Krishnan from Bengaluru, India, I will be happy if you can share some words on your work, geographic disparities in oral cancer survival in India, insights from National Cancer Registry Program.
Yeah, thank you everyone, and sorry for the inconvenience caused. So oral cancer is a significant health issue in India and its neighboring region. Globally, it is the 16th most common cancer, but however, it is a second leading cancer in India after breast cancer. So hence, we framed the objective is to estimate the 5-year survival of oral cancer from Indian population by stratified by different characteristics. So for this study, we taken the data who are the oral cancer patient who are diagnosed between 2012 to 15, and they have been followed up till 2021. So based on the quality and completeness of the data, we included the 10 population-based cancer registry out of 25. Then we estimated the actual survival and age standardized relative survival using ICSS weight. So we found the overall survival of oral cancer survival in India is 35% approximately, which is lower than some of the Asian region or high income countries where it is more than 60%. We observed disparity in survival across the population-based cancer registries in India. We can see there is a 50%, more than 50% survival at the end of 5 years in Ahmedabad urban, and in Manipur, which is lower than 15%. And when we look at the survival by different characteristics, the stage, localized stage has a better survival, and the early aged diagnosis had a better survival, and also the urban resident had a better survival compared to the rural population. So this study aligned with the WHO global strategy on oral health to understand and monitor the oral health at a population level. So to conclude, this study identify the disparities in oral cancer survival across the India. We emphasizing on promoting early detection and early and timely diagnosis of high risk group of oral cancer patient to improve the survival outcome. Thank you.
Thank you very much, Dr. Krishnan. And now we have completed the presentation from our great contestant, and it's my great pleasure to let the stage again to Dr. Rosso, to the most important part of this ceremony.
Thank you, Lydia. Now it's time to declare the winner of this year round. So I know that you are excited to know finally who are the winners of the main prize and the special prize. So starting with the main prize, the winner of the Anglesio Prize 2024 is Ellis Lotman from the Netherlands with a study on guidelines versus real-world data in metastatic bladder cancer, a population-based study on first-line chemotherapy treatment pathway. Congratulations. Dr. Ellis, do you wanna?
Yes.
Are you
Thank you.
happy?
Yes, of course. Thank you very much for the organization for giving the opportunity to give the talk here today, to read all the dissertations and look at the presentations, and also congratulations to all the other contestants because I love to watch all the presentations today. And yeah, thank you very much.
If I remember well, you already competed in the past, yes?
I think a few years ago.
Yeah.
2021. Yes, indeed. The competition was tied with some other competitors. And the message is also this, compete again. So you will have sooner or later the opportunity to win. So it's
Sooner
also
or later you will win.
Yes, sooner or later, if you are worthwhile. And you know, I really stress this fact that there were at least 4 candidates that were very tight in the ranking, in the higher part of the ranking. So it was a tough competition this year. Okay, so it is time to declare the winner of the Elvo Tempia Special Prize, who goes to the youngest after the main winner. And the Elvo Tempia Special Prize this year goes to Florina Suter from Switzerland, with a study on effect of the COVID-19 pandemic and lockdown on cancer stage distribution and time to treatment initiation using Swiss cantonal cancer registry data. Congratulations, Florina.
Well, thank you so much. Thank you so much. It's such a big surprise and a bigger honor to receive this award. I really want to thank all my co-authors, the whole team, because such a project is not possible alone. And also congratulations to all the others. You have very interesting projects going on. And yes, thank you very much.
Thank you, Florina. So you have the age for competing again and again for the main prize. Okay. And now, the third special prize, the Harald Zurhausen new dedication, that goes to the best scoring candidate coming from low and middle income countries. This year goes to Natalia Godoy from Colombia, with a study on age-period cohort effect on incident trends of child leukemia from 4 population-based cancer registry in Colombia. Congratulations, Natalia.
Thank you. Thank you very much. It's such an honor to receive this prize, and it's a motivation to continue our efforts in strengthening our research in cancer and in cancer research. So thank you very much. And I would like to thank also all my colleagues and co-authors of this study. And thank you. Thank you very much.
So now we have the winners, and as you know, all candidates will be recruited in the alumni committee, and Lydia Sacchetto will now report shortly on the activity on alumni committee. This is what it constitutes our community, our young community that is growing and growing and helping us in keeping this prize going on. Please, Lydia.
Thank you very much, Stefano. And it's a pleasure for me to update you on the alumni committee activities and to share with you some great news. As you know, the alumni committee was established back in July 2021. It currently counts about 180 members, and it is led by the cabinet, who members you can see in this slide. And I want to really thank Ben, Diana, Daniel, and Yuri for their efforts and all the efforts they dedicated to the committee and to create a community over the last years. The committee aimed to develop a dynamic network of relationship between winners, participants, and friends of the Enrico Anglesio Prize, and to connect young researchers all over the world to share knowledge, experience, to follow career developments, and to celebrate success. And with this in mind, the Cabinet proposed and organized different activities summarized here over last year, some online and some in person. We can start from the first get-together that we had last year in Granada, Spain, more or less during these days, during the ENCR IACR conference. It was a hybrid event with a good participation both in presence and online. And it was organized to strengthen the connection, to allow the alumni to meet and to share experience in an informal setting. Then we hosted virtual webinars, and specifically the last winners of the Enrico Anglesio Prize, Dr. Alice Bernasconi, and the winner of the Elvo Tempia Special Prize, Dr. Giulia Capitoli, had the opportunity to present their work. It has been a big success, with high attendance, vivid discussion, and a lot of interest. If you miss it, you have the opportunity to access the recording on the Elena Moroni YouTube channel. You can simply scan here the QR code and subscribe to the channel to remain updated on its content. Indeed, the Alumni Committee contribution to this channel is part of what I referred here as our online presence. The Alumni Committee has also a LinkedIn group, which is by invitation only group, but we will be very happy to include each of you. So feel free to reach out to be included in the LinkedIn group. The group is used to increase visibility, to improve exchange and interaction between and amongst alumni. We also advertise there some job position and interesting conferences. Then we also have an alumni page on the Fondo Elena Moroni website, and each alumni has a personal space with photos and its bio sketch that can be accessed from there. Finally, we also have a listserv tool, which is a mailing list that can be used by every alumni to disseminate information, and which is also currently our main channel of communication. It's a moderated mailing list, so be reassured that you will not be spammed. And now I'm happy to announce that soon the Alumni Committee will welcome its first honorary members. As reported in the term of reference of our community, honorary members are eminent researchers in epidemiological and oncological fields, or any distinguished person who contributed to cancer control and to the Enrico Anglesio Prize or the Alumni Committee activities and duties. Once appointed, the honorary members will contribute as advisors and mentors. We have already identified the first two honorary members, and they will be announced soon. So please stay tuned, check the alumni page on the Elena Moroni website to keep informed. And finally, a great news. The Fondo Elena Moroni grant again financial support for the Alumni Committee activities for 2025. So if you have any idea or proposal, feel free to reach out. Don't be shy, and let's discuss together on the opportunity to concretize your idea and to make things happen. And with this, I will give the stage to Dr. Zanetti for the closure of the event.
Thank you, Lydia. Usually, when we close the ceremony, we say, see you next year. So, see you next year. We don't have decided yet if next year it will be an online running of the prize, or if it will be possible for us. We have the resource for organizing also something in presence. We will see. At any rate, announcing the next edition, the edition of 2025, I could comment that this is the 20th edition of the prize. The first edition has been 20 years ago, 19 years ago now, with the opening edition in 2006 in Palma de Mallorca. And I have noticed that in the presentation of Dr. Catalano of today, the first slide, there were the co-authors. One of the co-authors of Dr. Catalano is Professor Fulvio Riccieri. Professor Fulvio Riccieri has been the winner of the first edition. That means that we are now covering 2 generations of research. The winner of the first edition are now professors, and we are assisting at the participation of their student to the Enrico Anglesio Prize. So this is a big satisfaction to already have a long story. So see you next year. Thank you to the member of the jury, and thank you to all the participants of this edition.
Grazie a tutti,
Thanks a lot.
complimenti. Well
Well
done.
done, everybody.
Thank you so much.
Bye-bye. Thank you for organizing.